My name is Stephen Little. We're at the Houston Methodist Hospital in Houston, Texas. With me as my guest today is Dr. Jonathan Lindner. Jonathan is coming to us from the Knight Cardiovascular Institute in Portland, Oregon, where he is the M. Lowell Edwards Professor of Cardiology. He's just given us a grand rounds on molecular imaging, and now we're going to follow up with just a few questions and sort of delve into that topic a little more. Hey, Jonathan.
Hi there.
One of the things you talked about briefly was sort of three big categories of application for molecular imaging. And I think you had basic R&D, preclinical, clinical, and then kind of full-on clinical. Could you just give us kind of a little summary of the activity and the excitement in each of those categories?
Yeah, sure. So, molecular imaging gives you unique information that can be used in many different fashions. So in the clinical realm, the hope is that by being able to get more precise information from imaging that we may be able to diagnose disease in an earlier state. But really one of the big promises is precision medicine, to be able to essentially not treat every single patient with a disease the same way, but actually to treat them with therapies based on the phenotype of their specific disease. It may also give us a unique way of actually being able to measure responses to therapy. But it's important to also remember that a lot of these new exciting diagnostic agents that are being used, including molecular imaging, can be used not just for clinical diagnostics, but actually can be used to test new therapeutics. In other words, a great way of figuring out if a drug is working is to see whether or not it's actually having a molecular effect rather than an effect on the morphology or the tissue function. So that may give you an earlier indicator that it's a effective drug or an effective therapy.
Okay. One of the things you talked about was the use of P-selectin and VCAM ligands to target or to identify with imaging the earliest aspects of coronary atherosclerosis. So clinically, we're often now used to using calcium scores to identify preclinical disease, but it's kind of mid to late in the cascade of inflammation. So how far are we from, as a clinical tool, being able to see that earliest signaling of atherosclerosis in a way that we can image and then maybe make treatment decisions on?
Yeah, it's a very good question. So that question really has several parts to it. Number one, why do we want to image P-selectin and VCAM? So for those of you who aren't familiar with these processes, essentially atherosclerosis starts with the entry of inflammatory cells into the vessel wall. It's an inflammatory disease. And so if you can actually detect and image the early inflammation in a blood vessel wall, you may actually be able to detect really high-risk disease at a very early stage. Now that whole strategy really depends on us having some sort of a clinical decision to make based on it. Right now we don't have that. Right now we have, and we look at markers that we can do something about. So for example, we look at cholesterol levels because we have therapies that we can use to reduce the cholesterol, reduce the inflammation associated with it. So these are kind of pie-in-the-sky ideas, but we already do have some early detection schemes, like using calcium. Now the problem with calcium is you really need a certain amount of inflammation in the blood vessel wall in order to detect the calcium. So there are other techniques that are being developed to look at calcium formation. So things such as sodium fluoride imaging, which can detect before there is a significant amount of calcium, actually detect the calcification process. So all of these technologies are really geared towards detecting aggressive disease at an early stage where you may be able to have more of an impact using therapies rather than waiting for really end-stage disease.
Okay, great. One of the questions I had during your rounds was the ability to use microbubble imaging to look at large vessel shear stress, wall stress. And I don't know if that's been done, if somebody's looked at that in terms of, is it the vasa vasorum imaging, or has work been done in that area?
Yeah, so different contrast agents that we use for perfusion imaging, blood flow imaging in the heart and in the blood vessels, they all behave slightly differently. A lot of the tracers that we use in radionuclide imaging, they don't really look at blood flow, they look at some sort of an uptake, cellular uptake, which is governed or influenced by the amount of blood flow. That's essentially what's used for most forms of radionuclide imaging. For MRI, you have a contrast agent that stays within the bloodstream, but it can leak out as well, so it diffuses out. The technique that you're referring to, which is contrast ultrasound, is relatively unique in that it uses a really large particle. These are microbubbles, 2 microns, so think about them as being about the size of platelets. And they behave just like cells, and they stay within the vascular space. And so they can really map out kind of where there is not just microvascular flow, but where there is patency of the microcirculation. So one thing that you just mentioned was vasa vasorum. So in vasa vasorum is very much like a cancer. There are tons of blood vessels in vasa vasorum, but very few of them actually have active blood flow going through them at any one time. And so using a perfusion tracer, sometimes it's hard to actually tell how much blood flow is happening through these vessels. But something that can actually just detect single blood vessels by looking at a microbubble flowing through it can sometimes give you a little bit of information in terms of just the presence of microvessels. So yeah, so the bottom line, different perfusion imaging techniques can give you different pieces of information. Some of them are more advantaged for looking at certain aspects of flow, good spatial resolution, good sensitivity, and other ones are better for looking at very small, infrequent events like contrast ultrasound.
Okay, great. Now you're a national, a global expert on molecular imaging and contrast specifically. So that's a pretty unique career path. Can you tell us a little bit about your training to, the more classic training to become a clinical cardiologist, and then how that morphed into this really was a fairly basic science focus, but still married with the clinical.
Yeah.
I think viewers would be interested to see how you got there.
Yeah, that's a really insightful question, and I think it's a really fun question to kind of answer. So, for young scientists, a great way to make your mark in science is to find a unique niche. And the way that I got to where I'm at, and the way that I got to becoming a pioneer in contrast molecular imaging with ultrasound is essentially through unique opportunities. So I went and trained in a laboratory that was developing these ultrasound microbubble contrast agents. Why? Because I thought that these were really neat things to be able to study microvascular physiology, and we're using them to study microvascular physiology. But as a fellow in the laboratory, I was exposed to many people giving talks on vascular biology. And so after being in the lab for about a year or two, I thought to myself, well, this is kind of unique. We could actually take some of these contrast agents and alter them so that we can actually look at vascular biology. How did I do this? Well, essentially, I spent first year or two of being on faculty, as junior faculty, in a vascular biologist laboratory. So I'd already trained in cardiology. I trained a little bit about microvascular physiology and contrast agents. I got a little bit of preclinical research under my belt. And then I went to go train under somebody completely separate, which is a vascular biologist. And then I was able to kind of put everything together to help develop this new field of molecular imaging. And I guess the bottom line of the story is be opportunistic. Think a little bit out, I hate to use the term outside the box, but think independently, think broadly, and go take advantage of your local expertise and go in directions that nobody is necessarily occupying, because it can be an extremely fruitful and great way to start a career.
Fantastic. One of the many hats that you wear is, you run what is a very large and I understand world-class primate research facility. Talk a little bit about how that came to be and how that is integral with your imaging research.
Yeah, so right off the bat, so I'm actually a division chief at the Primate. I don't run the Primate Center. So there are 7 different national primate centers throughout the country. These are, there's many laboratories that use primates. The primate centers are essentially national primate centers in that they are supported by the National Institutes of Health. So the infrastructure and a lot of the support money goes to make it so that doing research at these facilities is not that expensive. So for example, at our facility, we have 5,000 monkeys. It's on a separate facility from the main campus. And the idea is that there is so much work going on right now in small animal models of disease. We've got, in cardiology, for example, we've got all these mouse models, genetic mouse models of heart failure and atherosclerosis. And there's always questions that arise, how applicable are they to real human disease? And especially in the field of like omics, if you're studying genomics and epigenomics, there's it's a big leap of faith to say that what you see in an animal model, small animal model, applies to humans. And so one of the first things that I did when I moved to OHSU was to start investigating ways that I could get involved in non-human primate research. And by virtue of the fact that these centers are supported by the NIH, it made it so that it wasn't that much of a cost issue. Mm-hmm. One of the things that's always in the backs of everybody's minds, especially on that campus, is humane treatment of animals as well. And this is something that I believe extremely strongly in, which is these animals are precious. And once you start working with them, you understand very quickly these animals have personalities, they're sentient beings. And so one of the things that I hope to do by coming to the Primate Center is to bring a lot of expertise in non-invasive imaging. So we're actually building a primate multimodality imaging center. So we already have a 3T magnet and a bunch of ultrasound systems out there. This will have angiography, SPECT CT, PET CT, more ultrasound systems, as a way of being able to use state-of-the-art imaging to look at these animals and treat them fairly, treat them kindly and with respect, without having to create harm.
Great, okay. One of the other hats that you wear in the leadership role is you're incoming president of the American Society of Echo. Mm-hmm. How do you see that sort of dovetailing with your research interests, and is there a message you can provide to sort of younger imagers, mm-hmm. sort of pulling that together? I mean, it's a fascinating career path to do all that.
Yeah, this is a challenging job. So the American Society of Echo is, I believe it's the largest subspecialty cardiology society. You know, we have over 17,000 members and a lot of international presence. There's a lot of things going on. You know, there's things that are going on in education. Mm-hmm. There's a lot of advocacy activities going on in terms of policy and reimbursement issues. There's always guidelines. So, Steve, you're the incoming chair of the guidelines committee, which kind of sets the tone of guideline documents. But there's also a lot of research activity and scientific and scholarly pursuits that we want to be able to support through the society. And so every president kind of puts their stamp mm-hmm. on their presidency. And one of the things that I'm putting my stamp on is really reinvigorating the science portion of the society. And specifically, you know, a lot of my background, you'd asked me earlier about my background of how I got to where I am and what the unique training opportunities were. A lot of how we got contrast ultrasound into patients and developed perfusion imaging techniques meant that we worked side by side with engineers. So the people who are developing the imaging systems, or the people who are developing the contrast agents, we worked side by side with them, looking at how they behaved, how we could image them, improving things, applying kinetic models, all of these things. And so we you know, all of us who spent time in that laboratory have a great understanding of kind of what's under the kimono in terms of the technology and the ultrasound systems. And that's starting to be lost. I truly believe that now clinicians who do ultrasound imaging and all forms of imaging are being fed all of this new technology without really knowing some of the limitations or how it can be really appropriately applied to patients. And so one of the things I'm going to try to do is to really reinvigorate the relationships between clinician scientists and just clinicians and the engineers who are producing some of the technologies that we're going to be seeing over the next decade.
Great. Well, Jonathan, I really want to thank you for visiting us at Houston Methodist. I know the clinicians, the scientists, the fellows, the sonographers, everybody involved in our cardiovascular team is really glad you came to visit.
I'm really happy to be here. Spectacular institution. So
thanks a lot.
Thank you.